Hello everyone, welcome back to Critical Care Survival Guide. We're going to be talking about oxygen delivery devices next. This can be a subject of a lot of confusion amongst residents who don't understand exactly how much oxygen which device can deliver. So I'm hoping to clarify some of that today. By far and away, the most common delivery device you're going to see is a nasal cannula. Nasal cannulas can provide varying FiO2s, that's fraction of inspired oxygen, depending on where the oxygen concentrators turn to on the wall. All right. At 1 liter, we increase our FiO2 from room air, which is 21%, up to about 24%. And then with each subsequent liter, we increase by another 4%. Nasal cannulas by themselves max out at about 6 liters, or about 44%. The next type of device is also a nasal type of cannula, but it's a little bit thicker, and it's called Vapotherm. Vapotherm is new technology that works by using high humidity oxygen and coupling it with a high flow. And what this enables is a higher FiO2 to be delivered to the patient because their oropharynx and dead space airways work as a reservoir so that when the patient inspires, a higher concentration of oxygen is delivered with each breath. Think of it a little bit like a non-rebreather mask, which I'll show you shortly, where the bag is the reservoir that fills with oxygen. In the case of Vapotherm, the patient actually becomes the bag, and the patient becomes a reservoir with each subsequent breath, so that as they inspire, they entrain that oxygen that is accumulated in their oropharynx and dead space airways. Vapotherm is particularly useful for patients that require high oxygen but still want to, say, eat or want to have a more comfortable way of getting their oxygen than, say, a CPAP mask or a tight-fitting mask. Vapotherm is also useful in people that have thick secretions because the humidity can help thin some of the secretions. As we move away from nasal cannulas and into masks, the first type of mask that you'll see commonly is called a Venturi mask. Venturi masks can deliver a precise amount of oxygen, or FiO2, based on the aperture of the plastic device just below the mask. Shown here, these apertures come in different colors that correspond with varying FiO2s. Venturi masks provide a flow of oxygen through the plastic apparatus at varying FiO2 concentrations. This is different than a simple face mask, which works more similarly to a nasal cannula, which is controlled by a concentrator on the wall. Simple face masks allow entrainment of room air with each breath. In addition, simple face masks can only get up to about 60 to 70% FiO2 at a maximum of about 10 liters. Again, that's controlled by the wall. Non-rebreather masks are a type of mask that can get us up to higher FiO2s, even up to 100%, more similar to Vapotherm. Like Vapotherm, they work through use of a reservoir, which is the bag that sits in the front. This bag will fill up with high FiO2 oxygen, and with each breath, that patient will entrain that oxygen into their lungs. It's important on non-rebreathers to note that we don't want these bags to be collapsing with each breath. We want them to remain full because that's a sign that the bag is fully inflated with oxygen from one breath to the next. The next type of oxygen delivery device you'll see are tight-fitting masks that are associated with CPAP or BiPAP. We call this type of delivery device non-invasive positive pressure ventilation. Important to note that this is a positive pressure type of mode where we're actually forcing oxygen flow into the patient. So in addition to delivering oxygen, we're also improving ventilation or CO2 exchange. The first type is CPAP. CPAP, or continuous positive airway pressure, works through setting a pressure level at one specific pressure, usually 5 to 10 centimeters of water, and this pressure comes at the patient irrespective of if they're breathing in or breathing out. Just like when you're riding in a car and you stick your head out the window and air is blowing at you and your cheeks puff out like a dog, as shown in this picture, the CPAP is causing that air to be rushing at your face. You can still breathe in and out, but just like your cheeks pop out, your alveoli pop out as well. And this causes the oxygen to remain held at the alveolar interface longer, increasing the diffusion of oxygen and the oxygen delivery to your patient. CPAP also works in obstructive sleep apnea by providing a pneumatic splint, or splinting open the airways to prevent the obstruction events that occur at nighttime. So CPAP is used for obstructive sleep apnea. It can be used with soft tissue obstructions of the oropharynx, and it's also helpful for cardiogenic pulmonary edema, where we're trying to use pressure to push that fluid back out of the alveoli and into the interstitium. BiPAP is very similar to CPAP, except that with BiPAP, on inspiration, you get an even higher level of pressure. So BiPAP works at two pressure levels, an inspiratory pressure called IPAP and an expiratory pressure called EPAP. Typically, we titrate the inspiratory pressure to a tidal volume that can be seen on the BiPAP machine, just like you would on a ventilator on an intubated patient. BiPAP is particularly useful in situations where we have trouble oxygenating and trouble ventilating. That's because the IPAP improves tidal volume, which will improve ventilation. So some of the situations where you may use BiPAP are shown here. Improvement in gas exchange to decrease a patient's work of breathing or dyspnea. We see it used in COPD exacerbations, sometimes asthma exacerbations, congestive heart failure, post-extubation respiratory failure, neuromuscular disease and weakness, and we often bridge between the ventilator and supplemental oxygen by using BiPAP, again, to help decrease patients' work of breathing. Advantages of non-invasive positive pressure ventilation is that it can avoid the use of a endotracheal tube, and it can also provide a mechanism for a patient to bridge while they diurese or while their steroids kick in for their COPD exacerbation. There are some things you need to know about non-invasive ventilation about when not to use it. It should not be used for these reasons: hemodynamic instability, that is if the patient's hypotensive; decreased mental status if the patient can't gag or protect their airway; if the patient has worsening respiratory acidosis in spite of already being on non-invasive positive pressure ventilation; if the patient won't cooperate, they keep pulling their mask off; or if the patient has impending respiratory failure based on lab or clinical criteria. So I hope this quick review of oxygen delivery devices was helpful. Don't be afraid to ask your respiratory therapist if you have questions or need help with setting these up. Thanks. Welcome to the next installment. That was a bad start. Hello everyone, welcome back to Critical Care Survival Guide. We're going to be talking about oxygen delivery devices next.